All right, off we go. Again, Dr. Dillard here. It is fall 2020, week 2. It's Thursday. It's all these lectures rolled into one. A lot of slides today. But it's a big lecture. It's a 3-block lecture. All right, but we'll go fast through this. It's not very complicated, I don't think. Heterotropic gastric mucosa. Heterotropic gastric mucosa, also known as ectopic gastric, esophageal ectopic gastric mucosa. Or, that's not a very good term there, heterotropic gastric mucosa, because that could be anywhere. That could be in the appendix, it could be in the small intestine. So really, the title should have been esophageal ectopia. And that's got some, because you have to say esophageal unless you say inlet patch. But you still should say esophageal inlet patch. Other AKAs, esophageal ectopic gastric mucosa, heterotopic gastric mucosa. What are we even talking about? It means that the patient has a little patch or a foci or focus of real gastric epithelium. Could be complete with fundic glands and could secrete hydrochloric acid and pepsin and intrinsic factor, the whole 9 yards. The only trouble, it's not growing in the stomach. It's actually growing inside the lumen of the esophagus. And it's typically found right after the upper esophageal sphincter. It's about a 2 millimeters or 2 centimeter circular patch. It's a red velvety tissue. Let's take a look at what it looks like. So here's an endoscope, and we're heading down. Lower esophageal sphincter is way down there, but here's exactly what this inlet patch is. And histologically, that is stomach tissue. And you could imagine some of you are thinking, ooh, that's probably not a good place to secrete acid, is it? No, because we're in this esophagus is not designed to take on acid. So everything I said, it's below the the upper esophageal sphincter. The prevalence is surprisingly high in this. This is not a 0.01. 4% of humans have a little bit of this. Most of it's asymptomatic, though. It's not a very big patch, but can be symptomatic. Histologically, it's real stomach tissue. That would be simple columnar tissue. And it has real glands. Sometimes, and you can never tell where the glands are from because there's different types of glands in different regions of the stomach, right? The fundic glands are the big ones. Those are the ones you study. Parietal glands is the AK for those. Those secrete hipster, as we will learn, is the mnemonic for that. Fundic glands secrete hydrochloric acid, intrinsic factor, and pepsinogen. Just converted into pepsin. Cardiac glands, where do they secrete? Just mucus. They're not a very exciting gland. How about the antral glands? Where do they secrete? Mainly big G, gastrin. That stuff is coming. So yeah, so you can have this patch, depending on how big it is, it could be secreting quite a bit of acid and it can irritate the esophagus. You can also get an H. pylori infection in this esophageal ectopia, right? And that could be irritative, especially if it's antral. It'll stimulate the release of gastrin, and that'll be a hormone, so that'll be released into your blood, and gastrin drives the fundic glands and makes them secrete the hipsters. Typically, as I said, the condition is completely asymptomatic. Occasionally, these patches can produce acid and pepsin significant quantities, which can cause damage to the esophagus, inflammation, and you can end up getting GERD symptoms with this going on. Not because there's anything wrong with the lower esophageal sphincter, but if you create acid from inside the esophagus, the lower esophageal sphincter holds the acid in, doesn't let it move down into the stomach. It's just kind of sitting there, and it can be fairly disabling to the point you have to have it removed. you could develop a Barrett's esophagus. In fact, 5%, 5.6% of people with Barrett's esophagus actually have concomitant esophageal ectopia. Symptoms, we're going to use these words over and over and over again. Well, if you got a raw, rough spot and you swallow and food goes over it, it's going to hurt. So it might cause odynophagia. Maybe you'll just feel uncomfortable, not real pain, then it's dysphagia. After you swallow, because that area's been stimulated, you might feel like something's stuck in your throat. That's globus. And it can refer pain to the sternal region, either retrosternal or peristernal. Pain and heartburn pain, right? So it can simulate GERD as well. It can probably refer to the heart as well. What's the treatment? Exactly the same. We're going to talk about GERD today for gastroesophageal reflux disease. So proton pump inhibitors, H2 blockers, and you got to be careful what you eat, and there's some GERD rules that we're going to look at. Medication, if it's an inflammation, you can take corticosteroids. If it gets infected because the mouth and the esophagus are dirty, it could get infected. You might have to take antibiotics for that. And if you can't keep it at bay with these types of things, you're going to have to go in and remove it surgically, which sounds like an easy deal, but you never know. After you remove it, you might scar. You never know how much someone will scar. If they scar a lot, you'll always have dysphagia because it'll cause a roadblock there, beaver dam. All right, that's all we'll say about that. So let's talk about the dreaded, the famous. Now these are definitely on boards, right? These are Canadian boards, American boards. This is favorites. Pathology teachers' favorite stuff to talk about these motility disorders. So let's meet the esophageal motility disorders, also called esophageal dysperistalsis is another way to say that. Well, they're considered functional. Think about that. Functional esophageal obstructions. Now, what does that mean without looking any further? Functional. Well, functional, that means that there's no real physical, mechanical, as opposed to mechanical esophageal obstructions. That means something physically is blocking it, but functional means there's not a mechanical block. It's actually a peristalsis doesn't work. Remember we said when we talked about peristalsis also not only has to push the bolus of food, it has to reflex open the lower esophageal sphincter so that bolus can slide into the stomach. So something's messed up with that, and you have a lot of trouble swallowing because of that. There's 4 types. Get your note card out, lots of stars here. You need to memorize, and all of these have to be memorized for sure. And we'll talk about each one of these. So let's talk about the famous Nutcracker esophagus. It's a relatively new AKA called the jackhammer esophagus, but I think it's probably will be Nutcracker esophagus. It is one of the motility disorders. Its prevalence is about like Marfan's, 0.01%. Now these patients, here's the key. So they have normal peristalsis in the upper half of the esophagus, or the proximal half. But the problem with Nutcracker esophagus people is the distal half of the esophagus. They still have a normal coordinated wave of peristalsis going down, but for whatever reason it becomes way too strong. So strong that you ever get a spasm in your calf? Everybody's got a cramp in your calf or somewhere. That hurts, right? Same deal. It's almost like a spasm, but it's still, the peristaltic wave is still moving, but it's too strong and too much power, and it can hurt. And it can crush the food. It can become so strong. So the food doesn't go down the pipe. It gets run over like by a steamroller. So, but that's only in the distal part of the esophagus. So you could say they have dysperistalsis in the distal esophagus. That equals Nutcracker esophagus. What's the cause of this? We don't know what the cause is. It's mysterious. It's some problem with the enteric nervous system. Maybe it's firing too much. We don't know. This would be a great chiropractic study. I don't know of any study on this. I was actually going to do some of these studies with Stanford before the darn SARS-CoV-2 hit and kind of messed everything up. But I have actually my gastroenterologist is very interested in doing this and studying dyspepsia as well. But anyway, so we don't know. Some problem with the enteric nervous system. You go in there and do a biopsy, unlike other causes of esophageal trouble where you can find something. There's nothing there. So we don't know what the story is with Nutcracker esophagus. But again, that extra strong peristalsis can definitely trigger nociceptors and stretch receptors to the point they become painful. And then, as I said, sometimes the peristalsis is so strong that the food gets run over and flattened. Symptoms, same old symptoms: dysphagia, dynaphagia, globus, chest, precordial pain, chest pain. I could have just as easily put retrosternal pain in there. They're all pretty much the same. Now these people, because the food gets flattened and stuck in the esophagus, they might be burping up and regurgitating. Burping up is probably a more intuitive word, but they're spitting up food that's got stuck in the esophagus, so that's quite common. How do you make the diagnosis? Well, you have to remember we talked about mammometry, where you stick that wire through their nose and it goes down into the stomach. It has those pressure sensors, and then with that mammometry set up, you have the patient do 10 separate swallows of water, and then you record the rhythm of peristalsis. Is that normal? The strength of peristalsis. And then you note the lower esophageal sphincter. Is it opening properly when the bolus of food is heading at it or heading toward it? And unusually strong peristaltic contractions in the distal esophagus on all swallows, but normal peristalsis in the proximal esophagus makes the diagnosis. So every swallow is messed up, which is not true for some of these other ones we're going to be talking about. We've looked at that before. There's your mammometry setup. Okay, if you want to get technical, there's no stars on the slide, but anything greater than 220 millimeters of mercury of force of pressure is that's enough to make the diagnosis as well. But it has to be on all the swallows. I almost took that. I should have taken that slide out of there. What about some associations? Well, turns out that some people have it Nutcracker worse than others. And about half of these people have a hyperactive lower esophageal sphincter. What does that mean? That means that the lower esophageal sphincter is too darn tight, and therefore it's stingy. It doesn't like to open, so it makes the swallowing process even more messed up, right? Because if that's not going to open, even if it does, the peristalsis push, even if peristalsis does push the food all the way down, if that lower esophageal sphincter is not going to open right, that food's going to get run over. It's not going to make it into the stomach. So those 50% are much more disability than the people who don't have the hyperactive lower esophageal sphincter. The treatment, what's the treatment of this? Well, the key is to try to calm that distal esophagus down when peristalsis occurs. And that's easier said than done. The same medications, the nitrates that are used to vasodilate the coronary arteries are used. And yeah, they vasodilate the smooth muscle, the blood in the smooth muscle, and makes that relax. So that's probably the more important part. It relaxes the smooth muscle. Then we have calcium channel blockers. Can also do the trick, cause vasodilation and relax the smooth muscle as well. Botox injections are fairly decent at giving symptomatic relief. The trouble is A lot of times the effect wears off and has to be repeated, and sometimes it doesn't work so good. And then there's a big complication rate, 16% complication rate for over-relaxation of the esophagus, and then your peristalsis. Then you have trouble the other way. If peristalsis is too relaxed, you get food stuck and you get dysphagia. Uh, and if it relaxes the lower esophageal sphincter too much, then you're going to get acid burping up from the stomach all the time. Gastric contents burping in the esophagus all the time, which is not good. And there has been some deaths from anaphylaxis with it. I don't think that's a huge problem anymore, but that's still a chance. The ultimate, if you're really miserable, the ultimate is surgery. It's procedures called esophageal mammometry or myotomy, esophageal myotomy, and the surgery loosens up the distal esophagus. They do it with an endoscope. They go down in the middle and they just put cuts and try to loosen that up so it doesn't contract so hard. And you can imagine that's geez, they could scar up the esophagus. They could cut too much and make it too loose, maybe not cut enough and not fix the problem. So there's all kinds of complications with that surgery. The most common one's probably esophageal stricture, where the scar tissue occurs in the cuts, and then then you can't fix that anymore. You go in there and try to fix that, more scar tissue will form. And then it could damage the lower esophageal sphincter, where that doesn't work, and you get GERD. So you get a rare problem where, well, it's not rare, it happens with GERD too, but you not only have dysphagia, maybe adenophagia from the scarred up pipe. You can't get food to slide through a scarred up pipe well. And then if that's not bad enough, the lower esophageal sphincter is shot and you're getting acid regurgitating up all the time. So you got GERD on top of that, and the GERD can make the scar tissue even worse, which will worsen the stricture. All right, so that's the Nutcracker. Then we go to DES. The diffuse esophageal spasm. So that's fairly rare. We're not 100% sure what the prevalence even is on this. During swallowing, here's the deal with this. The distal 2/3 of the esophagus, it contracts like a crazy person. Remember, Nutcracker esophagus, rhythmic peristalsis. Even though the distal esophagus is way too strong, there's still some rhythm there. In diffuse esophageal spasm, it's crazy. There's no peristalsis. It's erratic peristalsis in the distal part, the distal 2/3 actually of the esophagus. The other difference is with a Nutcracker, it happens in every swallow, but not with DES here, diffuse esophageal spasm. It doesn't happen on every single swallow. So that's one way you can differentiate the two. And then the other way to differentiate on diffuse esophageal spasm, there is no peristalsis. It's just crazy. Nutcracker esophagus, and we're differentiating these two because they're similar. Nutcracker has normal rhythm, has normal rhythmic peristalsis, but it's just too strong distally. Both diffuse and the Nutcracker, the problem is in the distal portion of the esophagus. Typically, the diffuse esophageal spasm is a little bit greater. Usually in Nutcracker, it's the half of the esophagus, and this we said was the distal 2/3, so 66% of the distal esophagus. That's kind of splitting hairs there, though. So it can block the movement of food. It can block the movement, of course, food in the bolus. It's because if peristalsis isn't working, you're going to get food stuck, right? So then you're going to feel dysphagia. You'll feel adenophagia or dysphagia or adenophagia. And patients, it can be quite disabling. Patients don't want to eat because they don't want to feel that pain of the esophagus going crazy, so they choose not to eat and they lose a lot of weight. The hallmark of this disease is on mammometry is 80% of the swallows are normal. So this one's a little harder to catch. Only 2 out of 10 swallows showed the crazy, uncoordinated spastic contraction. And so that's, remember, on Nutcracker, all of the swallows were affected, so only 20% are affected. But when you do catch it, it has a classic radiographic appearance when they're doing a barium swallow. When you can order a barium swallow, and they swallow barium, which shows up as white on X-ray, and on fluoroscopy, which is a kind of a moving X-ray, and you can see this classic corkscrew appearance. And corkscrew esophagus is DES, right? It goes with diffuse esophageal spasm equals corkscrew. Make sure you know that. They'll get you in radiology on that later if you don't know that. I don't think you've had those classes yet, but I'm getting you right now. You got to know. And when you see, and I might even throw this picture on the test. That is the strangest things you've ever seen, isn't it? Now, there's the stomach right there. There's the cardiac region of the stomach. And so what's going on here? Well, the peristalsis is cuckoo. It's went crazy. And it usually presents this weird kind of corkscrew appearance, right? Diffuse esophageal spasm equals corkscrew esophagus. Got it? Got it. What are the symptoms? The same old song and dance: dysphagia, odynophagia, chest pain. You could get precordial pain. You could get GERD pain. It can be all that stuff. You could fuse it with a myocardial infarction. All of these things are basically the same. All right, number 3, Achalasia. Okay, this used to be called cardiospasm. Hopefully that one's taken off the test, but you never know because it's so commonly confused with a heart attack. Esophageal achalasia is another AKA. And of all the motility disorders here, this is the one you don't want to miss because these patients are miserable, maybe even suicidal, some of them, because it's quite disabling. It is the most easily recognizable motility disorder, and it's best defined as a motor disorder because we can actually find some histological stuff wrong on this one. It's rare. They think it's about 0.01, like Marfan syndrome. It's also seen oftentimes concomitantly in people who also have adrenal insufficiency, Addison's disease to be exact. And remember, Addison's primary adrenal insufficiency, that's an autoimmune attack. And so that's exactly what we think is going on. Now, Robbins doesn't say autoimmune yet, because this just started popping up around 2012, and it's going to take that book probably. Although, fairness, I haven't looked at the 2020 version yet, which just came out. But in 2016, it wasn't there yet. But it does look like achalasia is one cause, at least, is autoimmune. What's it characterized by? So you have a spastic lower esophageal sphincter. So this is the first one that's part. Although remember we said the Nutcracker, 50% of people with Nutcracker have spastic lower esophageal sphincter. So could it be confused with Nutcracker then? But they have a spastic lower esophageal sphincter as well as crazy dysperistalsis of here's the key, the entire esophagus. Remember the other conditions we just were talking about, the distal esophagus. Now we got the whole esophagus having crazy peristalsis. And when you do mammometry, it's not on all swallows, but on most swallows you will see it. It's not like DES, only 20% of the swallows. It's more than that. There's a classic triad of symptoms. And here they are: incomplete relaxation of the lower esophageal sphincter when food is heading at it. It's got to be tested with mammometry. There's an increased resting tone of the lower esophageal sphincter when you're not swallowing. And then there's dysperistalsis of the, should put that in red too, right? Entire esophagus is gone cuckoo. And on most of the swallows, this will show up. So it's very, very disabling. So what's the pathophysiology of this? It's definitely a problem with the enteric nervous system. If you do a histological sample anywhere in the esophagus, you will find that Arbox plexus, or aka myenteric plexus, is degenerated and inflamed, and there's destruction in there and there's loss of ganglion cells in there as well. It's wrecked, it's inflamed and destroyed. We can see that, and this is the only one we can actually see that on, is Achalasia. The exact cause is still debated, but it appears to be a destructive inflammatory process which knocks out and destroys Arbox plexus. There's two big causes. Some viruses have been thought to cause the inflammation. There's definitely inflammation, but the question is who is causing it. And then we have this new, in 2016, this antibody. They're just calling it the anti-myenteric plexus antibodies. There's a few of them, as noted by this researcher back in 2016, and they're building on that work now. And these autoantibodies are attacking some part of Arbox plexus. It doesn't like the looks of it. Maybe cigarette smoke soaked through the esophagus and manipulated some genes. It turned on some genes that are not supposed to be turned on. Now all of a sudden the body's immune system goes, ooh, we don't like the looks of that. Have never seen that look before. It must be foreign. We must attack, and now you got yourself an inflammation. Pollution. We don't know what's turning on these genes, but the body is turning on the Arbox plexus. What are the symptoms? Same old song and dance. Dysphagia, adenophagia, burping up food, chest pain, weight loss. Could have thrown sternal pain in there, retrosternal pain, peristernal pain, any of those symptoms. Patients typically don't have all of them at once, but they typically have a couple of those. I almost took that out because I'm not sure how important that is. How about making the diagnosis with barium swallow? So this is pretty easy. So you order barium swallow or barium study, and here's the key. Remember this one. What's spasmed in this one is the lower esophageal sphincter is spasmed, and the esophagus is kind of limp. It has a weak peristalsis most of the times. And therefore, it looks like a bird beak. The barium looks like a bird beak where it's pinched off in the lower esophageal sphincter and it's backed up. Actually, it looks like a perfect beaver dam. Let's take a look at it. It's definitely not a corkscrew, right? And so there is the spasmed lower esophageal sphincter. And then this region is not working. The peristalsis is kind of broken because of Arbox plexus is messed up. And so it's limp, and that's what it looks like. The classic bird beak appearance of the lower esophageal sphincter being in spasm. That is Achalasia. I might throw that picture on the test, so make sure you know that. How do you make the diagnosis? Mammometry again, and there will be no peristalsis detected on 9 out of 10 swallows. Okay, so that's it'll just be limp. There won't be enough. There's no wave. It's just a limp peristalsis. Lower esophageal sphincter will be in spasm as well. And yep, histology. If you go in there and you take a sample, you'll find damage within Arbox plexus. It'll be inflammatory cells in there and some scar tissue, and it's pretty much dead in there. There's actually two. Robbins breaks it down into two types of Achalasia. There's a primary Achalasia where we know what's going on. And so neurodegeneration is occurring in Arbox plexus. Esophagus is limp. Cause is not 100% known, but it's probably, Robbins didn't know it, but it's probably autoimmune at this point. The second one is also classic. The cause is known. And this is some diseases like Chagas disease. It's caused by the Trypanosoma cruzi, which goes in and destroys our box plexus, aka my enteric plexus. That's the one spread by the kissing bug. So here's my chance to do a little parasitology. So you know I'm going to jump on that chance. So make sure you know the kissing bug. I think you've had that already, but you've probably forgotten it. Diabetics, I mean, diabetes is notorious for messing up nerves, right? You can get horrible chronic pain, peripheral neuropathy from that. You can lose your eyesight. It can also get into your enteric nervous system and destroy your ability to swallow. And same with these other tissue diseases, amyloidosis, sarcoidosis. Gets kind of thickens up the tissue, makes it scar, and you can get that in your esophagus and can knock out the Arbox plexus. What are the treatment goals of Achalasia? Well, you have to loosen that lower esophageal sphincter, which is really the only goal because we really don't have a good way to stimulate peristalsis. Right? We can loosen up the lower esophageal sphincter by these sticking a kind of a balloon down here, similar to where they do balloon angioplasty or angioplasty to the coronary arteries, where they jam that down. There's like a little guide wire, and then they slide this down, and they blow this up. This has a name. It's called bouginage or bouginage. And standard balloon dilation is not strong enough to fix this, so it has to be a much stronger type of balloon. In fact, they're using even something called a steel type of balloon called a pneumatic balloon dilation, which is even stronger than bouginage. And there's some risk for it, but it's pretty good at smashing the lower esophageal sphincter out. But you immediately can see the problem with that, right? If you overstretch the lower esophageal sphincter, what's going to happen? Well, if you overstretch it, now you're going to have GERD. You're going to have acid reflux. So you might have fixed your swallowing problems for a while, but now you have a GERD. But GERD's a lot easier to treat, I think, when we follow the rules of GERD compared to swallowing. I mean, what can you do? There's not much you can do about dysphagia. Okay, is that bouginage? That's that's the pneumatic balloon. That's the steel balloon that they put in there. There's a little guide wire, and they slide this in here, and this thing automatically pops open, and it stretches out the lower esophageal sphincter. Great, but hopefully that lower esophageal sphincter will be able to close again, and that's the problem. So the ultimate, if none of that stuff works, and the problem with this is they go in there and they open the lower esophageal sphincter, and it just gets stiff and tight again. So it's not a permanent fix. So the ultimate end of the road treatment is a esophagomyotomy, esophagomyotomy, or myotomy. I just say it by looking at it. Esophagomyotomy. And that's a procedure where they go down there and they try to loosen up just the lower esophageal sphincter, similar to what they did with Nutcracker, where they try to loosen the entire distal esophagus. But now they just focus on the lower esophageal sphincter. They come from the outside. This is a laparoscopic procedure. And it's yielding about 80 to 85% relief in patients. Seem to be fairly happy with it. But the trouble is they usually do too much, and it fixes the dysphagia, and they're left with GERD. But again, I'd rather have GERD than dysphagia because you can treat the GERD, as we'll find out here in a while. And if you have GERD, then you have an increased chance of precancer, which can turn into a real esophageal cancer. Barrett's esophagus is a precancerous esophagus, has to be watched like a hawk so it doesn't turn into the real type of esophageal carcinoma, which is one of the worst cancers out there. And there is erosive esophagitis, which is where we're headed here. We talked about the lower esophageal sphincter, and those gastric folds are way down here, so yeah, we got some pretty bad GERD there. Other ways to try to loosen the lower esophageal sphincter: Botox has to be repeated. You can develop antibodies against it, so that's probably not the best way to go. You can try to pharmacologically relax the lower esophageal sphincter with nitrates and calcium channel blockers. It's not the best way to do it. Okay, what about this one? Hypocontractile esophageal disorders. Not hyper, but hypo. So that sounds like, well, hypo, that means that the peristalsis is not working strong enough. And that's exactly what it is. And the lower esophageal sphincter is also it's not super stiff and cranked down. It's too loose all the time. And that we'll learn that's the cause of GERD right there in most cases. Where this lower esophageal sphincter, you've lost the tone of your sphincters, and there's no way to really fix that by exercising it. But here's the difference between this and GERD. They both have weak lower esophageal sphincters, but this one has weak peristalsis. People with GERD have normal peristalsis, but not hypocontractile esophageal disorder. And diagnosis is made via mammometry testing. And there's some kind of serious diseases that go along with this: scleroderma, dermatomyositis, amyloidosis again, inherited visceral myopathy, sporadic visceral myopathy. So those are some nasty diseases that cause muscle weakness. So that's not a great thing. Some other diseases even, it's part of Crest syndrome. It's considered esophageal dysfunction. Mixed connective tissue diseases can present like this. Muscular dystrophies, family visceral myopathies, all of these are muscle weakening diseases. And GERD may be one of the first signs that you've had something like that. But don't freak out about it, because more likely than not, it's just, especially if you're getting older, it's just run-of-the-mill GERD. Mixed symptoms with this. So GERD symptoms: the loose lower esophageal sphincter promotes GERD, so you get burning and acid reflux and heartburn. But if you don't have peristalsis, food's going to get stuck when you swallow it. So you're going to have dysphagia and odynophagia as well. So another one of these mixed kind of symptoms. What makes the diagnosis? So mammometry again. 50% of wet swallows demonstrate not much peristalsis, a wimpy peristalsis. And then the tone of the lower esophageal sphincter is shot. It's a loose lower esophageal sphincter. Let's see. Note, this pathology is not an AK for GERD. As I said before, GERD, both this hypocontractile disorders and GERD, they both have lower esophageal sphincters that are too loose. But GERD patients have normal peristalsis. These people do not have normal peristalsis. What's the treatment for this one? SOL. There's not a lot you can do other than fight the GERD symptoms by using the techniques we're going to talk about right now. And that's the end of that section. So we've been talking about it. Let's officially talk about gastroesophageal reflux disease. And it occurs when a person frequently regurgitates stomach contents into their distal esophagus. And you may have no idea that this is actually happening. You don't have to burp it all the way up into your mouth to have GERD. It could be going on and you have no clue. And the stomach contents, of course, contain usually hydrochloric acid and pepsin. And that is very caustic to the esophagus, as we've talked about already. The common symptoms are called heartburn. It's typically a burning pain that feels like it's underneath the sternum or even the xiphoid, or it's called a retrosternal pain. It's typically, if you want to see if you have GERD, you can eat a really heavy maybe go Mexican and eat Mexican food. I'm not being racist either, because my wife is Mexican and I like Mexican food. I think it's still safe to say that. Have some chili peppers in there. And yeah, so pig out. Maybe have a margarita with that. And if you really want to test, then go to bed and sleep on your left side and see what happens. That's like the worst combo. Oh my gosh, I wouldn't even dare do that. Um, so yeah, here's another rule about GERD. If you get heartburn more than twice, 2 times a week or more, you have GERD. If that happens like every week, back to back to back, you have GERD. What really causes the pain? It occurs when the stomach acid and pepsin seep through the epithelial layer. Remember we talked about the layers of the esophagus? And it gets into the lamina propria where there are nerves. And it might even go further into the submucosal layer and have hit the nerves there as well. Remember this? We talked about this. So this is the esophagus, lower esophageal sphincters kind of pinching in. But we can see the red here. That is the mucosa, stratified squamous at this point, 3 layers of it. And then the muscularis mucosae is here. And then underneath it, they didn't draw it in, but there's arteries, veins, and nerves right under here. That's the lamina propria, the muscular layer. Then if you go further, they still didn't draw the nerves in, but that's the submucosal layer. And there's definitely, I mean, that's where the miser who hides in the basement, Meissner's plexus lives in there. Right? And there's Arbach's plexus between the muscularis externi layer. Oh, I drew them in there for you. All right, we've been through that. So GERD versus reflex esophagitis versus ulcerative esophagitis. What is this? Gets confusing. So here's the deal with this. If the reflux causes visible esophageal inflammation on endoscope, so you go down there with a scope looking around and oh yeah, the esophagus is all red looking, then you have yourself a diagnosis of reflux esophagitis, meaning inflammation. Also meaning there's no ulcers. If you see not only redness, but you see lesions, ulcers, then you have yourself ulcerative reflux esophagitis, inflamed and ulcer. This one, of course, is more painful, more likely to bleed and have complications with that one. A little epidemiology. It is the most common diagnosis put forth by gastroenterologists. That's where you refer your patients to, right? Gastroenterologists for these people. In the United States, 20% of Americans have this diagnosis. What? 20%. This is a huge, huge problem. Typically strikes people over the age of 40. As the age increases, the chances of someone getting it increases. And it's not uncommon for children to have it. I have a what is he now? He's 11, but this happened when he was 9. I had a 9-year-old had to go through Stanford to try to figure out what was wrong with him because he was having GERD. He was on PPIs, just like his grandpa was. That was my problem for a long time until I figured out how to beat it. So it can happen in young kids. The symptoms strike almost 40% of adults have at least one episode of heartburn per month. And so that's not really called GERD if you only have, right? It's got to be twice a week to have the diagnosis of gastroesophageal reflux disease. But occasional heartburn, I mean, they just have to live with. That's not enough to go on PPIs or anything like that. That's just almost kind of normal, especially if you're older. As of 2013, 11 million people have received a prescription for a PPI, which is a proton pump inhibitor. That's the number one, and that is by far the most effective treatment for GERD. I was on those for years. Tried to come off them. Forget it. I'm off them now, though, thanks to getting this class. Interestingly, the degree of patient symptoms don't always predict the severity of the esophageal damage. They could go down there and find nothing. That's the same with disc herniations, right? That's a very famous study with disc herniations, lumbar disc herniations. You'd think the worse the disc herniation. What are the 3 categories of disc herniation, by the way? I should test you on that. 3 categories of disc herniation. Disc hernia is a parent category. There's 3 children. Protrusion, that's usually a contained by the posterior longitudinal ligament, 4 millimeter herniation. Extrusion is bigger, but the disc hasn't broken loose. The herniation hasn't broken loose from the main body of the disc. And then a sequestration, and that means that a piece of that herniated disc is actually broken loose. Those are the 3 types of disc herniations. Famous study on that. They thought sequestrations must be the worst, and there was actually the smaller ones were more problematic than the big ones. Those small little contained, and that holds true. Those are the worst ones to have. The discectomy doesn't work good for them. Flexion distraction treatment doesn't work. Those are just a really bad type of herniation to have. Anyway, how did I get off on that? But anyway, same deal with this. The pain is thought to be, part of the pain anyway, comes from the capsaicin receptors in the esophagus. Some research on that. Pepsin can damage, trypsin can even damage the esophagus all the way from the duodenal juices. Because if your lower esophageal sphincter is really lax, then your pyloric sphincter is probably lax as well. Your anal sphincters are probably lax as well. So you probably have a little trouble down there in all these places. Hiatal hernias, which I think we'll get to, but I have YouTube videos on those and our high yield stuff. Those can increase the chances as well for GERD, because like the most common hiatal hernia is a sliding hiatal hernia, and your esophagus, your abdominal esophagus, slides into your thoracic cavity, and there goes your lower esophageal sphincter. It doesn't have the esophageal hiatus to beef it up anymore, and you lose that function. You get GERD super easy like that. Other symptoms, frequent acid regurgitation in your mouth, dysphagia. This has surprised me, this number. 30% of people with GERD have some dysphagia as well. How can that be? Well, the acid burns the end of their esophagus. The lumen of their esophagus is burnt and raw, and maybe even has ulcers. So when food slides over that raw meat, it hurts. So that's where the dysphagia comes, or adenophagia. Water brash they can also have. We talked about how the chronic bathing of the mucosa can irritate the cardiac glands to oversecrete mucus, and you're coughing that mucus up all the time. I don't think I told you, some people get it all the way up into the mouth. If you get that acid up into your mouth enough, it can actually irritate the salivary glands. It can go up through the salivary, through the ducts to those glands and get into the gland and irritate that. And then you oversecrete the salivary juices. So that's another part of water brash. I can't see that happening too often, but I can certainly see the mucus happening. Adenophagia we talked about. Burping, nausea, vomiting, those are some other less common symptoms. And then the scary thing about GERD is, especially older people, they don't have any symptoms at all. And maybe their first symptom is dysphagia, where it's like, God, I can't swallow. Something's messed up there. They go in and do an endoscope, and lo and behold, they have cancer from a Barrett's esophagus, or maybe they have GERD and ulcers down there, and it's developed scar tissue and kind of clogging the beaver dam in that pipe. So, for example, one study found 33% of patients with a Barrett's esophagus had no symptoms. They're surprised. How can I have a precancerous esophagus? I don't even have GERD. So it can definitely happen. Pathophysiology of GERD, we kind of talked about it. A hypotonic, relaxed, over loose lower esophageal sphincter. And if that's not tight, then it can't seal the stomach acid from burping back up into the esophagus. It's really as simple as that. There's a little anatomy we've looked at. There's the diaphragm there. So there's the esophageal hiatus, and this would be the lower esophageal sphincter. I think the author could have made this a little bit thicker. Nevertheless, lower esophageal sphincters here. This is the abdominal esophagus in green. The Z line, the author should have put that. That should be right about at the level of the diaphragm, so they could have raised that a little bit. But yeah, we've talked about all that. Remember, this is stratified squamous, non-keratinized, 3-layered, kind of modified. And then below the Z line, that is columnar, simple columnar, just like the stomach. Just like the cardiac region. There's no parietal glands or anything there. Just like the cardiac region, there's just mucus-producing glands there. What are the risk factors? Starting to see a lot of stars now because you're going to have to consult patients who have GERD. They're going to come to you miserable and asking you about this. And this is, you can really make a big difference in someone's life. So if you want GERD, how do you stimulate GERD? Overeating. So if you eat tons and tons of food and pack it into your stomach, then your stomach, as it has to digest that food, it pushes that food right up into your esophagus. And you young people, that's fine because your esophagus just won't, it was pinched shut by your lower esophageal sphincter. Someone like me, if I overeat like that, the esophagus becomes part of my stomach because there's just not much of a lower esophageal sphincter there. Eating right before you go to bed is a big no-no. Let's everybody say this right now. Right is wrong. Repeat after me. Right is wrong. So never eat right. That's the hint again. Never eat right before going to bed. And if you do, don't you dare sleep on your right side because you'll get GERD for sure if that lower esophageal sphincter is loose. And the other thing, there's some rules about what you can and cannot eat. But that's the big one. Overeating, going to sleep on a full stomach, and then eating the wrong spicy, like Mexican foods can be really, really spicy, and salsa and things like that. And I guess there's other foods. I don't eat those. What does my wife eat? Curry or some? I don't know. There's other spicy foods out there. So just spicy foods in general, you got to be careful. Alcohol, you got to be careful. It relaxes the lower esophageal sphincter, which leads us to this slide thing. What are the things that relax the lower esophageal sphincter? Well, getting old, there's not much you can do about that. Alcohol is a depressant. It relaxes the lower esophageal sphincter, and if it's loose, it's going to really be loose after you drink some alcohol. Some of our patients with chronic low back pain, what's the doc prescribe them? Valium. Valium is like Soma. So Soma is a classic muscle relaxer, but if they have a little depression, docs prescribe Valium, which will take care of the muscle and kind of calm the depression down. And that is a powerful, both of these, Soma and Valium, are powerful depressants. So that will relax the lower esophageal sphincter and make you more likely to have GERD. Unfortunately, chocolate. I love chocolate, but I can't have chocolate. Not only because of my GERD, because I have palpitations. I have heart arrhythmia as well. And so chocolate makes my heart go cuckoo, so I can't eat chocolate. Double reasons. So those are some things that. And here's some more. Hiatal hernia. We talked about a hiatal hernia, especially sliding hiatal hernia. Stress, not much you can do about that, but that has been, some studies showed, to relax the lower esophageal sphincter. There's some association, not that the osteoporosis is causing it, excuse me, but there is some connection, it seems, between osteoporosis and GERD that we're wondering if it has something to do with PPIs. So that's kind of a emerging area of research right now. And then some people just have relaxed lower esophageal sphincter and we don't know why it does that. We will talk about ZE syndrome, Zollinger-Ellison syndrome. In a nutshell, it is a gastrin secreting tumor that usually lives in the pancreas. And if you have a tumor, there's the pancreas, here's the tumor. If it's secreting gastrin into the bloodstream, let's see, can I draw a stomach? I don't think I've ever tried to draw a stomach. There's the stomach. So the gastrin goes over and it hits the parietal cells, right? There's a gastrin receptors on parietal cells. It's going to stimulate that to make hydrochloric acid like crazy. So high levels, and you can't shut it off. There's no mechanism to shut it off. So you have acid in your stomach all the time, people with this ZE syndrome. Esophageal motility disorders like the transient lower esophageal sphincter relaxations, they can have GERD. Weak esophageal peristalsis, if they can't clear acid that they burp up, they can have GERD. Anything that increases the intra-abdominal pressure in your abdomen can cause GERD. It's squishing the stomach and kind of squeezing the stomach juices and digesting food. It's pushing them up. So people who are obese, people who are pregnant, people who have heavy lifting occupations, they're always doing Valsalvas. They have higher rates of GERD than other people. Chronic coughing, people with COPD have GERD. BPH, we're not exactly sure. Oh yeah, BPH is straining for urination. That's right. So some people with bad BPH, that's blocking or squeezing on the prosthetic urethra, it's hard to pee. So they have to literally push down and strain to urinate. And that increases the chances for GERD. What causes the pain? I almost took these out because we've talked about this before. But again, and this, I just threw this in here. Of course, the stratified squamous, they don't have these microvilli, right? So I keep saying I'm going to Photoshop those out. But your stomach's, here's your pipe. So this is your esophagus going like that. And here's your stomach. All right, so you're burping up acid. It's coming up here, and it can't get through the cell, but it can get between the cells. So once the pepsin and the hydrogen ion burns through these tight junctions, it's off to the races. The desmosomes and the zona adherens, these anchoring junctions, they have no chance at stopping the acid. None of this stuff does. So it gets down here, and the lamina propria is right down here, and there's nociceptive fibers, and it burns those, and you got yourself pain. In fact, once this gets opened up, you might not even have any damage up here on the top because all the acid just leaks down through here so quick. The top of these cells is spared. And that's a specific syndrome we'll look at here in a second. And everything I said, the tight junctions get destroyed, and the acid can go down there and burn the nerves and the lamina propria, and even get into the Meissner's plexus down there in the mucosal layer and burn those as well. And it can spare the epithelial layer. And here's a little cartoon of that, showing the pepsin and the acid dripping down kind of through they got too many layers here. No, that looks about right. But stratum basale would be here. Actually, the nerves would be, they got that messed up. The nerves would be down under here in the basal lamina. But nevertheless, that's that same thing I just drew. But here's the deal with this. So for endoscopic evaluation, some people will be, in fact, look at this number. 50% of people who have significant disabling GERD will finally get in to see the gastroenterologist and finally get in to have an endoscopic evaluation done, and the doc comes out, nope, I didn't see anything. And that's not unusual. It's 50% of the patients. Why? Because your tight junctions are destroyed, and when you regurgitate, the acid just runs right down into the underneath the epithelial layer, and it doesn't damage the top of the epithelium. And they have there's a certain word for that. And here's the cartoons going down. There's inflammation in the lamina propria there. But there's a certain GERD, though, that 50% of people, they're not GERDs, they're NERDs, which stands for non-erosive reflux disease. So to be a NERD, you have to have a endoscopic evaluation that was normal. I was a NERD. I've had several of them. They could never figure out what's going on until finally the esophagus was okay, but finally the acid was coming up into my vocal cords, and I was having trouble lecturing. And I'm like, what in the heck is going on? And that's when I got this class, and I started reading that sometimes the acid can go all the way up into your larynx. It can burn your vocal cords. So I went to the ENT doc, and sure enough, we stuck a scope down there. I could see it on the big TV. Huge ulcers on my vocal cords from acid, and that was the problem. Then I knew. I went through so much testing, and no one was smart enough to figure that out. It's like even Stanford, the GI doc at Stanford, I think he would have been able to figure that out. But don't get me started. That's why you got to be smart with this stuff. You got to, as you get old, you have to learn, because these doctors are just overworked, and I don't know if they don't pay enough attention. But that's why I'm in business. That's why my coaching session goes so well, because doctors don't spend any time with their patients. I often have patients come to me, they've seen 4 surgeons, and they've gotten 4 different opinions from 4 different surgeons. So it's just crazy out there. Anyway, let's get through this. I'm digressing again. So 50% of those patients are NERDs. Now the NERD may eventually progress to a esophagitis or erosive esophagitis, but they may not. They may stay a NERD for their whole time with this thing. There's another way to make the diagnosis where you can put a little pH sensor right just a little bit above the lower esophageal sphincter, and you wear that around for 24 hours, and then you turn that thing in, and it can sense how much acid has been burping up. Almost like a Holter monitor, which we'll talk about for palpitations and heart arrhythmias and stuff. You always wear a monitor around for 24 hours. Same kind of deal. There's a new one Stanford wanted me to do. They clip it onto your distal esophagus. I'm like, you want to do what? You want to poke holes in my esophagus to attach this thing? I said, that doesn't sound like a great idea for someone with a sore esophagus already. But they're working on things like that. But there's just not, when your lower esophageal sphincter is loose, there's just not a good treatment for it. The NERDs, there's some research on these NERDs. They're a pretty tough group to treat. They don't seem to respond well to the H2 blockers or the PPIs, or the prokinetics are pretty much all off the market now. The good ones are anyway. But the good news, only a small number of the NERD patients actually turn into erosive esophagitis patients. So they usually don't turn into, get those big ulcers and have trouble with bleeding and things like that. Erosive esophagitis, so we talked about that. If you have erosions down there, we've talked about if it's just redness, then you have reflux esophagitis. If there's erosions, it's erosive reflux esophagitis. You have to have ulcers on endoscopic evaluation. Sometimes it's just called erosive esophagitis. Sometimes it's erosive reflux esophagitis. But those all mean the same thing. So this is a patient with erosive esophagitis, and you can see this is all raw meat here. This is all burned away by acid. So it looks pretty painful. What are the classic symptoms of GERD? Well, parasternal chest pain or retrosternal chest pain. That's heartburn, right? It's burning pain underneath your breastbone or your sternum. Of course, we know it as the sternum. It could be down in the xiphoid region, which is usually where dyspepsia is, or stomach problems, and PUD, peptic ulcer disease, usually shows up down there. Could be in the heart. The precordial region is where your heart is. You put your hand over your left pec, is the precordial region, and the sternum, precordial region. In the larynx, we said it can get up into the vocal cords. I can guarantee you that's true. And they cause heartburn. Sometimes it's soured stomach or upset stomach, but heartburn is the classic layperson term for this. Some other symptoms of other common symptoms include acid regurgitation. Oh yeah, I know. I always, if I overeat, I can burp up that acid. Comes all the way up into my mouth. Sour tasting, odynophagia. We said, what was it, 30% of people with GERD have odynophagia because their esophagus is like raw meat down there and it hurts to slide food over it. Hypersalivation or water brash, as we talked about that already, from the salivary glands getting irritated, and mucus from the cardiac mucus producing glands of the distal esophagus. And then less common, doesn't happen that often, but you can get dysphonia, and that's what I had, trouble with horse and lecture. And I was even hospitalized for that because they thought I was having heart problems. They thought it was having a heart attack. So I was in the hospital 2 days. And they go, I don't know what's wrong with you. Turned out to be I had ulcers on my vocal cords. That was like, took me 6 months to figure that out. Don't get me started. It's too late to get started. It's early for you probably. It's like, what is it, 10 o'clock for me. I'm up late tonight. Past my bedtime almost. Chest pain, yeah, the most common cause of non-cardiac chest pain is GERD. And it can be, if you come into the ER, you really can't tell. It's hard just by the patient's symptoms to tell a myocardial infarction apart from an attack of GERD. And you got to be worked up. You get those troponin levels. People with GERD aren't going to have elevated troponin, but you still got to get worked up. Could radiate into the chest, into the neck, into the throat, into the scapula, down the arm. It's usually retrosternal chest pain, but it can be different as well. Here's kind of a way to time it too. So here's a way you can figure out if you have GERD. It usually strikes about 1.5 hours after eating a big, especially a dangerous meal like Mexican food, hot, spicy food. A lot of it was a margarita or some alcohol. And if the pain comes on, that pain in your sternum or maybe even kind of towards your trachea, probably GERD. It takes time when you eat any food, no matter if it's the dangerous food. It's not acidic down your stomach, so it feels good. It coats your stomach because it's basic. But as these acids are produced, then it becomes acidic, and stomach starts to churn and splash it around. If your lower esophageal sphincter is not shut, then your splashing is going to go right up into your distal esophagus. Classic old study with 500 GERD patients found this. That's over that 1.5 hours. They would eat right here at 6 a.m. and then about 7:30 is where they would spike with regard to symptoms. They all kept very accurate pain diagrams. They would eat at noon, and some of them got pain right away, but most about 1:30 or so spike, and same thing. They'd eat dinner at 6, about 7:30, bam, they'd get that GERD pain. Classic triggers, I'm just not putting any more stars on that. I put this big one to tell you this is going to be on the test. At least one, probably 2 questions on this. Classic triggers of GERD. Alcohol, we talked about. Caffeine, rough on the eroded esophagus, and it stimulates the production of acid. Spicy food binds to capsaicin receptors, and if they're already irritated from acid, it's going to hurt. Chocolate relaxes the lower esophageal sphincter. Red sauce is very acidic, and that will burn the irritated esophagus and stimulate acid production. We talked about overeating. High proteins will create lots of acid. Sleeping on the right side, right is wrong, right? What's the deal with that right is wrong? So here, remember your anatomy. So here is somebody sleeping on his left side. Left is cool. Left is, what's the same for that? Left is lucky. Left is, somebody will figure it out. But if you sleep on your left side, the fundus of your stomach is down by the mattress, just like this. So if you have some food left in your stomach, and it's liquidy, it's acidy, it's going to bump into the fundus and it won't go up the esophagus. But if you flip the guy over and you sleep, this is down, there's a straight shot up the esophagus. The esophagus is just part of your stomach. And of course, now all bets are off. If your entire stomach is packed with food, then it's not going to matter. It's still going to get squirted up there. But if you've waited 3-4 hours, at least 2 hours for young people before you go to bed, you probably won't have a full stomach. You look like something like this, and that'll keep it in the stomach. Some tricks to making the diagnosis. Well, we said the 90 minutes after eating a high-risk meal. We said that. Another trick is to, once you get the heartburn, take a bunch of Tums and see if you can make it go away. If Tums give you dramatic relief, like they always did for me, that's a pretty good sign that you have GERD. Watch out for those Tums though. Because if you're a stone former, you can definitely get kidney stones, especially if you're a calcium stone former. They can stimulate the formation of these stones called urolithiasis. You don't want to create urolithiasis with taking Tums, so be careful of those things. You could do this is kind of a tough one, but if you're using PPIs, proton pump inhibitors, we'll talk more about those next time. These are over the counter. They were not over the counter for many years. Now they're over the counter, and they definitely will work. The H2 blockers don't work, in my opinion, and the research shows they're only 50% effective. We'll look at why that is. But the PPI inhibitors work. The trouble is they take about, what does it say, may take 1 to 4 days. No, it may take, oh, there we go, 14 days. Yeah, it's really like about 2 weeks before these things kick on. So it takes a while for them to work. But after that, they definitely make a difference. They will shut down the production of acid, even though your body will try to overcome these things. But if you want to see if you have GERD, just stop taking them cold turkey. See what happens. If your stomach pain comes back 90 minutes after you eat, you got GERD. The gold standard, of course, is to stick a tube down there and look to see if they can find any redness or any erosions or ulcers down there. And that's the ultimate test. If you have disabling GERD, you're going to have to get that done. And you should get that done because you don't want to turn that into a Barrett's esophagus. People who don't treat this and take this seriously can develop a Barrett's esophagus, which can go on to esophageal carcinoma and kill you. It's a nasty, nasty type of cancer. We will talk about that. Here is some erosive esophagitis, right? Look at these. It looks like it's healing, but they're big lesions, right? Those are all ulcers for someone with severe GERD. Differential diagnoses. I do like my differential diagnoses. So GERD can simulate a heart attack, a myocardial infarction. It can simulate a pre-heart attack, a warning, angina pectoris, from myocardial ischemia, probably from coronary arteries being blocked by atherosclerosis. Pericarditis can simulate GERD. Dyspepsia, of course, from gastritis or the gastropathies. We'll talk about those probably in 2 weeks. Esophageal pathology, which we just talked about. Maybe a sternocostal inflammation could also do the same trick. GERD treatment, I think we are done. We'll talk about that next time. All right, email me those questions. See y'all later.